So welcome everyone. Hello and Yarmadat. My name is Faiz Jiwani. It is my privilege to be moderating today's critical conversation. To quickly introduce myself, I am a proud primary care provider here in the Houston area, where I have been privileged to partner with a community of patients to together ease the burden of illness as they pursue meaning in their lives. My patients face many of the challenges others do, supporting themselves and their families along with their health, and also bear additional challenges, including homelessness, language barriers, and a lack of medical insurance. And so, as you can imagine, I'm really pleased to be a part of our session today. I'm also involved in medical education on the social determinants of health, and I've participated in community level advocacy at the Baylor College of Medicine. Critical Conversations is an ITREB USA initiative which strives to engage the entire Jamaat with a particular focus on 18 to 40-year-olds. The series aims also to explore the critical questions of our time within the context of our faith. Before beginning the topic for today, in the spirit of justice, we'll begin with a land acknowledgement to recognize the history and exploitation of Indigenous peoples from where I'm speaking to today. I'm speaking from the ancestral lands of the Akokisa, Karankawa, Coal-Witikan, and Atakapi Ishak peoples, whose elders have stewarded this land for generations, and which we now refer to as the Houston area. We believe the work that we do in sessions like these include a responsibility to acknowledge the ongoing harm that is done to Indigenous peoples in these lands and work towards a society that is more just, equitable, and in keeping with our ethics as Ismaili Muslims. In keeping with that, today we'll be talking about voting and faith, exploring the inequities of the healthcare system. The session will explore the inequities embedded in the healthcare system and some of the specific populations who are affected, possible strategies to improve inequities within this system, and how and why working to improve the healthcare of these communities is a critical part of our faith. We're also eager to hear from you today. Please note the Q&A box below, through which we encourage you to share your questions and thoughts during the presentation. We'll try to address as many of the questions submitted as we can after the prepared questions. And as you've already experienced, we'll also be engaging directly with you through a series of poll questions, which we encourage you to participate in as well. So with that, I will briefly introduce you to our panelists for today. Firstly, I'll introduce Alisha Lalani. She is the Vice President of Business Strategy and Chief of Staff at Magellan Health, a national health plan for Medicare and Medicaid recipients, where she is focused on innovations to reduce cost of care and improve member experience for low-income populations and individuals who need long-term care or other specialized services. Prior to this, she supported government program growth strategy and product development with Evolent Health, a company focused on value-based payment models with hospital systems. Alisha was also previously with United Health Group, where she consulted with state Medicaid agencies and supported their implementation of state-based exchanges and other Affordable Care Act provisions. Alisha received her Bachelor of Arts in Women's Studies and Global Health from Emory University and her Master's of Science in Public Health from Harvard University. She currently serves as the chairperson for the Aga Khan Youth and Sports Board for the Northeast region and has held various leadership roles for Camp Mosaic over the last 15 years and Global Encounters since the program's inception in 2012. We also have Huzur-Mukhani Henna Budhwani. Dr. Budhwani is an assistant professor of public health at the University of Alabama in Birmingham. Her pronouns are she and her. She is an implementation scientist and health equity scholar working in HIV risk reduction and stigma mitigation strategies aimed at improving health behaviors and clinical outcomes among adolescents and underserved minority populations. Institutionally, Dr. Budhwani has also been a national board member with the Aga Khan Social Welfare Board, the national honorary secretary of the Ismaili Health Professions Association, and is currently on the editorial board for the Ismaili USA magazine. Dr. Budhwani has received the International Robert Carr Research Award from Human Rights Watch and Johns Hopkins Bloomberg School of Public Health. Domestically, she has received the Vulcan Award from the Mayor of Birmingham for her civil rights and advocacy work, was named a top 40 under 40, and was honored by the Women's Fund. And lastly, we have Huzur-Mukhani Fazila Lalani. Dr. Fazila Lalani is an assistant professor of emergency medicine at Hofstra School of Medicine and an emergency physician in Queens, New York. She works at some of the three hospitals that were hit the hardest at the early onset of COVID in the US, where she and her family were seeing up to 250 COVID patients every day. She was actually also infected with COVID herself. She went on to publish a handbook on COVID preparedness and has given multiple talks on the same and her experience as a New York City frontline staff member and patient herself at various hospitals in East Africa. She recently did a TKN assignment at Aga Khan Hospital in Dar es Salaam, where she helped set up the emergency department and bring their care to international standards of practice, training over 200 people around the country in primary trauma care, as well as set up an American Health Association International Training Center. Dr. Lalani was health board chairman of the Northeast region, the youngest in the country, and the Ismaili Health Professionals Association president. Thank you for joining us, everyone. So to kick things off, we'll ask each of our panelists to share a response to this. Can you share some of your background and work in healthcare, and how has your faith informed the work that you do? So we'll start with Dr. Fazila Lalani.
Thank you so much. You can hear me. So as Faiz said, I'm an emergency medicine physician in Queens. I thank you for being a part of this, allowing me to be a part of this critical conversation during this critical year and this critical election. As Faiz mentioned, I was the ER provider in one of the 3 hospitals that was the hardest hit in COVID. We were seeing hundreds of patients a day, transporting out hundreds of patients every week, because in Queens, we don't have a lot of health hospitals, as I'm going to talk about soon. And then, as he also said, I got COVID myself. And while people, like the people that got the most airtime were the people that were complaining about the, PPE that we had and all those things, some of us, myself included, felt like this was an amazing opportunity. Like, this is what I've been practicing all my life, learning all my life how to help people. And I finally had that amazing opportunity to be part of helping people and society when we need it the most. And I think I can really say that comes from my faith as being an Ismaili, and early on learning the importance of caring for other people, and also knowing about the inequities in the world, right? Because we're Ismaili, we hear for months from very young about the Aga Khan Development Network, where healthcare, what it's like around the world. From a very early age, I decided that I wanted to be part of improving healthcare around the world. My grandfather and my uncles and my dad are all doctors from India, and they moved to America. And I remember being very young and being like, wait, if you guys are practicing here, who's practicing in India? And just wanting to say, I want to be part of improving access to healthcare. And we have amazing healthcare in America, and making sure that that's everywhere. And so, as Faiz also said, it was supposed to be a 6-month TKN in Tanzania back in 2017. And some of my friends were like, you're never coming back. And they were right. I stayed for 2 years. I maybe would have never come back if I didn't meet my now husband. But I just had some of the most amazing experiences of my life. First of all, I had an apartment on the beach, which was beautiful. Tanzania is a beautiful country. I would go to Zanzibar every month and hang out on the beach. So I had a great life too. And then also my work at the hospital and being able to set up standards of care and improve the patient care that I saw that was given by my whole team was just nothing more rewarding than that. I'm actually getting goosebumps right now just talking about it. Yeah, that's it. And so I really think that, as I said, that's part of being Ismaili and growing up and appreciating what seva is. And if anything, sometimes when my mom fights with me and says, you have to pray more, and I say, my seva is my prayer. That's how I'm talking to God and how I'm, giving back to his people. And if you use that excuse, I'll support you. That's it. That's for me. Oh, we can't hear you.
We'll go to Dr. Budhwani.
Thank you, Faiz. Just like Dr. Lalani, I'm super excited to be here. This is a great group of panelists and also an amazing group of audience members. I mean, it's extraordinary under the circumstance to be able to talk to the Jamaat directly about, in this case, healthcare and structural considerations. So I'm a medical sociologist. I have a faculty appointment in public health at UAB, the University of Alabama at Birmingham. And similar to Dr. Lalani, I've worked and volunteered in the United States and abroad. From my time in Knowledge Nazrana, I was very lucky back in the Golden Jubilee. I was part of a team that conducted a project for the Agency for Microfinance out of Geneva in Syria, Afghanistan, Tajikistan, and Pakistan. And I actually spent time in Syria before the civil conflict decimated the country. And it was really extraordinary talking about those international experiences. You could just walk down the road, pick an apricot off the tree, eat it, and continue. So in terms of the question you've asked, Faiz, I think the desire to give of ourselves as Ismaili Muslims, it's just a beautiful aspect that is embedded in our religious and cultural identities. As to work, I currently have active research projects in the United States, particularly in the underserved Deep South, in Cameroon, and in Dominican Republic. I focus on elucidating the effects of stigma on health outcomes among minority populations. So that includes women, immigrants, and people of color, specifically young people of color. My focus is on those who lack power and who are considered minority populations. So in terms of minority, we talk in power, not in terms of numbers. Basically, the whole of my research, my teaching, my service, my seva is focused on health. So to address that question a little bit more, for years, the Ismaili community has referenced a need, and we've all heard this, for a spark to break the cycle of poverty and oppression. So I believe that through my research, I seek to identify what that spark is for different groups. And that might be rebalancing the power structure between patients and providers. That might be bringing healthcare into community settings, especially with populations that are skeptical of the healthcare setting. And it might simply be destigmatizing or reducing discrimination against populations that are overly affected. So I'm really excited to talk about these things today.
Perfect, thank you. Alisha Lalani?
Yeah, Yama, everyone, thank you so much for having me. And I'm just very humbled to be part of this group and this panel to speak today. As Faiz mentioned earlier, I'm a healthcare strategist focused on innovations in care and finance of care within government-sponsored programs in the United States, such as Medicare, which is for seniors and disabled populations, and Medicaid, which is for lower income populations. So where I am, we insure the most vulnerable individuals in the US, those who are facing really severe behavioral, mental, physical health challenges and concerns, all in the midst and backdrop of poverty, immigration issues, economic instability, and the like. And I actually don't think it's coincidental that I wanted to work for the most at-risk individuals in our country. As Ismailis, we're taught both implicitly and explicitly to give of our time and our resources for the betterment of communities in need. So even though on a day-to-day basis, I'm really focused on the business side of healthcare, my guiding principle is really to ensure the best quality of care and the easiest access of that care for those who need it the most and who are, frankly, navigating a system that really makes it difficult for them to get care. And so I think that that's always been in the backdrop for me. I think we were joking as we were preparing for this that we've all spent time in East Africa and in places like that, because I think it's ingrained in our system and in what we've heard so much growing up and in Hajj Imam's speeches, Hajj Imam's firmans, that do better for the world and do better for the community you're in. So, I started in global health thinking that that's what I wanted to do. And then the Affordable Care Act came around and there was so much that needed to happen stateside. And I said, there's so much that can happen here. So let's focus on what we can do here. And so since, for the last 10 or so years, I've really been focused on domestic care and trying to better our community. And I really think that just comes from our growing up and being in Jamaat and hearing Hajj Imam's firmans explicitly telling us to do that, and then hearing and seeing the selflessness and the commitment to the community that we see in our volunteers and the sevadaris that we have in our brothers and sisters.
Thank you all. I think I speak for many when I say we're very humbled to have you all here again with your different vantage points. And clearly there's such a breadth of experience here with individuals both in the United States and outside, and concern and effort that spans from individuals to society level work and research as well. So very humbled to have you all here with us. So now moving specifically to the topic of inequities, we have a poll question for the audience. And that question is, how equitable do you feel the healthcare system is? So I'll give you a minute to answer that, and I'll do that by just reading answer choices. So all groups of people receiving care in the healthcare system receive similar quality of care. Some groups of people receive worse care, but it is not significantly different. It is a concern, but less important than other more important societal problems. Or there are significant differences in how well the healthcare system serves some groups compared to others, and this needs to be urgently addressed. Okay, great. So we can go ahead and show the results. Okay, so near unanimous, but definitely interested in hearing our panelists' response to this question as well. So moving specifically to inequities, how have you witnessed or encountered inequities in your daily work? And we'll start with Dr. Fazila Lalani. You're on mute.
All right, yelling with again. So yes, as an emergency medicine doctor, I'm on the ground, and so my work in New York and in Tanzania and India, I would say the inequities are kind of standard around the world, I would say. One is access to care, right? That's generally health insurance, and that's usually related in America to finances and immigration status. Number two, I would say, is cultural understanding and language. And number three, which is new, is actually like housing, right? Which kind of goes into immigration status too. But if you live really close to your neighbors, with the new importance of communicable diseases, that becomes a new, very important thing to worry about with our health. So, I mean, just describing to you all what happens in an emergency department. The group here is like kind of focused on 18 to 40 on this call. And so there's a good percentage of people that are under 18, under 26 and have health insurance, their parents' health insurance. And then at 26, you say, oh my God, I have to pay for my own health insurance. Then health insurance, I've always worked at a hospital system, so I have health insurance. It costs me $350 a month. That's quite a lot. I mean, most people can't afford that health insurance. So what do you do? So if people come to me and they say the emergency department is completely free, you can go there. It's kind of like going into a store and going shopping, but then you get a bill after. You forget that there is a bill later on. You can get everything, the doctor tells you what you need, but you definitely have to pay for it later. And so that's what I said. Like, if you come to the emergency department, I'll tell you if you're having a major heart attack and you're coming with chest pain. I'll tell you if you're having a major heart attack or not, but then you need further testing at the cardiologist's office to test what's going on, what's the reason for your chest pain. And while your insurance, you might be able to have emergency Medicaid to cover what's in the emergency department, that further testing you need insurance for. And you're going to have to pay for that with cash. And then if there's something wrong, you're going to have to wind up paying that with your house. The same thing, if you come to the emergency department with a rash, I can treat you with medications, but you have to follow up with a dermatologist, especially if it doesn't work. If you like to speed like I used to when I was a teenager, or you don't have control of who else is on the road, you can wear a seatbelt. That's a great step in the right direction, but you don't have control over who is, coming at you. And then you're getting an ICU bill and you're paying with your house and your parents' house. My husband, I'll say, he cut his finger literally about less than an inch. He came to my ER. I did the suturing. He got a bill for $1,300, $1,000 for me to put one stitch in. And if he doesn't pay that bill, our credit score goes down and we can't buy a house, right? So it's all connected. It's not only that health insurance. So even if you're the healthiest person and you're not worried about, what they talk about on the news, which is those, prior health medical conditions, and you're healthy, you still have to think about having health insurance. And so what happens if you don't have health insurance? You have to wind up going to the city hospitals. At least there are hospitals you can go to get your health care. But the majority of people don't have health insurance. So they wind up going to the city hospitals, and the lines there are so long. There's, you get your tests ordered and there's nobody calling you back as your tests get lost in the mail, or you don't get the follow-up of, okay, I'm coming, you need another appointment, another health, you don't get that access to, you're not close to your medical doctors. So you're not getting the same quality care that you would get if you have health insurance. And I work in two hospitals, one in Queens and one which is like lower income, and I work in Manhattan which is upper income, and it's the same health system, say both Northwell, and just what's available and accessible to our patients is completely different within the same health system. The smiles, that you get when you walk in as a patient, the cleanliness of the hospital, the uniforms people are wearing, the responsiveness of the staff, and how quickly you get, with the one hospital, they'll call to make doctor's appointments for you. The other one is, okay, go figure it out yourself, even though you probably don't speak English. So lots of inequities if you have health insurance or not. Number two, I would say, is a big language barrier, is that I actually chose to work at the hospital I work at in Queens, even though a lot of hospitals closer to me, because I do speak Spanish. And so I want to be able to, help that small inequity in a small way by seeing more of my patients and having them have access to a Spanish speaking doctor. But then what about all the Russian, Bengali, and Mandarin speaking patients, right? We have to use an interpreter. It's just not the same. And truth be told, like it's for, every single time I go back to the patient, I don't feel like turning on the machine and, using the interpreter service. So some of the times I myself too, I'm admitting it, but just try to speak in broken English and hope that they understand. But is that really the best quality healthcare that you can get? And then the other reason I chose to work in this hospital in Queens is because it's close to Queens Jamathkana. And so I thought, okay, at least I'll be working and taking care of Smiley patients. But the reality is that most of them have the health insurance situation I was describing above. And so they have to go to the city hospital. So I barely actually see any Smileys. So it just gives you a sense of how much of our community really doesn't have health insurance. Even if the people on this call probably do, we're a little bit more literate. We're using Zoom on our Sunday afternoon, trying to get educated. The majority of Smileys and the world don't have that. That's all I was going to say. That's it. There's one more thing, but I forgot. It's okay. I'll say it later.
No worries. Thank you for that. So those are definitely very relatable examples, both to us as individuals and also personally to my own patient population here. So definitely national issues that are being brought up. So now taking a broader lens from the specific day-to-day experience of treatment, what are the inequities more broadly in the healthcare system? So we'll start with Alisha Lalani.
Yeah, thanks, Faiz. And I think Fazila hit really on a lot of the big categorizations of healthcare inequality in the US health system, right? She talked about disparities in coverage of care, right? How you're financing your means to pay for care. She talked about disparities in the actual care, your ability to access that care, and then also the treatment that you're getting when you do access that care. And then broadly, she talked about the disparities in the social determinants of health, right? The other aspects of your social, physical environment that really have a significant impact on your health and your health outcomes, meaning your economic stability, your food insecurity, housing instability, your education, your neighborhood, your built environment, the discrimination you face. All of that really rolls into health outcomes, and we're seeing a lot more focus on that. So if we look at each a little bit closely, right, Fazila mentioned insurance, and this really sits at the center of our country's political divide. And, we're talking about this in the lens of voting and the upcoming election, right? Your ability to get affordable care, your eligibility categories, your age, your income bracket, your underlying health issues, your pre-existing conditions, which everyone likes to use, right? And this often changes with administration. This shifts the definitions of each of this shifts. So you can see that healthcare, insurance, and politics are really inextricably linked. And I think we've all learned that over the last several years. And in most cases in the States, you're covered in a couple of different ways, right? Through your employer. If you're in a professional setting, you're covered through your employer. You're covered through government-sponsored plans like Medicare or Medicaid. You're self-insured. If you're a business owner, you're self-insuring yourself, maybe your employees as well, or you're uninsured. But as Fazila said, right, even if you are insured, depending on what you can afford in terms of premiums, deductibles, your pool of available doctors, of available hospitals, the technology that's covered in your insurance, it's all vastly different. And you can also be underinsured, right? If you're checking the box on having insurance, but there's coverage inadequacy, if there's one catastrophic event, or maybe just a finger cut, right? You could go into medical debt depending on where you are financially. And that financial insecurity is really a crux of an issue in the healthcare system. And make no mistake, right? This disproportionately impacts Black, Indigenous, people of color, immigrants, those are the ones who are truly impacted by this and really are teetering on financial instability that a healthcare event can just sway one way. And so the enactment of the ACA really was, the purpose of those provisions was really to make sure that, to reduce that financial danger and making sure for those who are uninsured or underinsured to be able to get the space to have insurance. But given how fraught our system is with political issues, right? So many of the provisions in Obamacare, as people call it, or the ACA, right? Those are state regulated. So what Obamacare did, or Medicaid, the ACA did, was expand the Medicaid access pool, right? So before it was a certain income bracket. Now it's a bigger income bracket, but depending on what your state has decided to do, like if you live in a Texas, a Georgia, Florida, and Alabama, you don't have the right to get Medicaid expansion. Yeah, Henna can now get Medicaid expansion, but if you live in a New York, a Virginia, California, you have the ability to get Medicaid expansion. So if you weren't, if you were making a little bit more than the traditional Medicaid member, but less, not enough to afford the $300 premiums, depending on which state you're living in, you can or cannot be eligible for Medicaid. And so, that's where you see the disparities in coverage. And then the disparities in actual care, what are your logistical abilities to get to the right care at the right time? When you do access that care, what implicit biases may be in place? What are the assumptions being made about the way you manage your care and the circumstances of your life? As Fazila mentioned, if you have an accent, what are the assumptions being made about your socioeconomic status and how you manage your health? And this really can impact the agency of a patient and their ability to get the right choices or be an advocate for themselves and the type of care they're getting delivered. And generally, right, taking a broader lens, there's really a fraught history of racial bias in the healthcare system. And that has led to a lot of distrust amongst minority groups and their desire to even access care or go seek care, right? Forced sterilizations, non-consensual experimental studies, legal immigration fears when seeking care. All of that really plays into someone's desire to go get care. And it really reduces the likelihood that people will seek preventative care or even other things before it gets too late. And then I think the third piece that Fazila mentioned, she mentioned housing, right, which is broader part of the social determinants of health, right? The social, economic, environmental factors that really drive health outcomes and impact individual health behaviors and lead to greater health disparities. And I'm hoping, I think Dr. Henna will talk about this a little bit, but just to give an example of this, right, as we think about the COVID pandemic, we're seeing a lot of joblessness. We're seeing a lot of social isolation. And those in and of themselves are not healthcare issues, but they create emotional stress. And you can see that in the substance abuse pandemic that we're having simultaneously, right? We're seeing increases in opioid use, even more so in the last few months. We're seeing a spike in overdose deaths. All of that is due to, we can relate that back to the social isolation and the joblessness. And again, those are more the social determinants and not really health factors, but really impact healthcare costs, your overall health. And so I think that you can see that there's a broader lens here that we can think about with healthcare.
Great, thank you so much. That's definitely a complex topic, and so thanks for walking us through various parts of that. So very much something that we can all delve further in, but I think that was a great primer. I also want to note, we did notice, I do want to acknowledge someone raised their hand. We'll be deferring all audience questions until the later portion of the session. So we do encourage you to ask questions, but please do put them in the Q&A box so that we can get to them later. So thank you, we do see them. Lastly, Dr. Budhwani, how do the inequities in the current system affect us? Okay,
cool. First, I'm sorry if you saw me spin around. I'm very clumsy and I took a sip of coffee and spilled it all over myself. So there, and then also Yalimadat to Mebu, who actually messaged all the panelists saying, Yalimadat, I'm here. So we see you. Okay, let's talk about structure. And I'm going to zoom all the way out to 1976. So I'm part of a relatively small cohort of Ismaili Muslims who was born in the United States who's above the age of 40. And so in 76, I was born at Cook County Hospital, which is one of the largest providers of indigent care in this country. My parents were undocumented, and I was born into poverty. I mean, it was really the classic parent who's a cab driver and all of this that we hear about from those early days. And this is just simply how my life started. I didn't pick these circumstances. I'm not saying whether they were bad or good, but basically structure was playing on me and limiting my abilities or enabling my abilities right from the get-go. In my childhood, then we moved to the suburbs, right? Which, while one would assume that a move to a wealthier part of town would produce a better life, the unintended consequence was that I was a brown-skinned kid in an overwhelmingly white community at the time. It's since gotten very diverse, which really meant that I was experiencing discrimination and stigma and brutality every day to some extent. And what I faced was so overwhelming that I couldn't even ride the bus to middle school without just being targeted. There were no safe spaces. This was not terms that we used back then. And structural forces were acting on me, pushing me to internalize that perhaps I was less than my white peers. While concurrently in the Jamaat, I mean, truthfully, I felt really misunderstood by my brown peers who were born abroad, and therefore they had this wonderful and strong cultural identity as Pakistani, Indian, or East African that I utterly lacked because of the circumstances that I was born into. Now, while society has shifted, and please tell me if this is boring, because if it is, then I'll change topics. But so while society has shifted to being more inclusive and the Jamaat and the communities have become diverse, I would suggest that in the past 4 years, we've violently swung backwards. Political forces have labeled and otherized us. We're Muslims, we're an immigrant community, we're overwhelmingly a brown subpopulation. So the challenges of the African American and Latinx community, our friends, are the same issues that we face, even within context of healthcare. Now, back to healthcare. So I'm a sociologist, so I got to be structural about this. So, I mean, in terms of where we start, let's bring this to the Jamaat. Let's bring this to our community. The number of older Jamaati members who are ineligible for Medicare because they migrated or when they migrated should sincerely worry us. Because as we age, we rely on healthcare for survival. I mean, to live to the next day. And if older Murids, which we know they do, lack coverage, do we as a broader Jamaat expect them to forego or ration care? Because truthfully, that's occurring right now. We also have Ismaili Muslim families in rural communities. They lack access to healthcare. We have Jamaati members with lower literacy, meaning they may not have a full understanding of what their provider is telling them to do. And I say all of this because the issues that we have depicted or seen depicted on television, that Dr. Fazila has talked about, that Alisha has talked about, those issues that we talk about affecting those other communities, those are our issues. They affect our Jamaat.
Thank you, Dr. Budhwani, and for sharing some of your personal experiences as well. Did you also want to share thoughts on the bigger picture policies as well?
Sure, absolutely. Okay, so zooming out even further. Where you live matters. The policies or the politics of your state affect your well-being, regardless of if you think they do or don't. They do. So I'm going to give you another personal example. I live in Alabama. We have a vibrant and growing Jamaat. And years ago, we needed to find a larger Jamaat kind of space as we do. Our Jamaat almost exclusively lives in a single suburban community. We found a great location in that suburban community, which would have been close to our Jamaat, right? We pushed for approvals. We did everything right. And even though our Jamaati members were residents, we were denied zoning. And we were told it was due to an increase of potential traffic. We all know, we suspect, but we all know it had everything to do with us being brown Ismaili Muslims. And so I implore the Jamaat to be thoughtful with their votes. While some Jamaati members understandably are concerned about the financial implications of an increase in the hourly minimum wage, an increase that could lead to a better quality of life for our brothers and sisters, which is very much a part of our tariqah, or are uncomfortable with certain social policies that don't minimize traditional values, but promote inclusivity, and dignity and equal human rights, which, by the way, also is a part of our ethos, a vote for a candidate who will work to ensure all Americans have health care, back to the topic, we will have a healthier Jamaat. That means we will have healthier, chubby babies. We will see lower rates of chronic disease that is decimating our Jamaat. We'll see expanding healthcare coverage that also means Dada and Dadi being healthy to pray for the welfare of our community. So this is all to say, Faiz, I know I'm rambling and I'm sorry. We experience structural forces every day. These are forces that constrain and enable our behaviors. Yet we're a community that fought against structure. To migrate, we were not forcibly brought to this country. Our families used our agency and our autonomy to relocate to the United States. We picked our businesses, and then we picked our universities, and our children picked their professions. And now we need to use that same agency and autonomy to pick our next president, who will, we hope, protect the Affordable Care Act, expand the Affordable Care Act, and make sure that all Murids across the United States have appropriate coverage.
Thank you, Dr. Budhwani. So, we do want to note that the views of all of our speakers that are expressed are the opinions and preferences of ourselves and the speaker themselves. But we do want to thank you for the openness in sharing these reflections, and we hope that everyone will feel comfortable sharing openness as well throughout the session today. But definitely a lot to think about, so thank you for that comment. So now that we've explicitly mentioned voting, here's another poll question for everyone. So if we could just have that pulled right up. So I consider candidates' views on healthcare when voting. So just give you a minute. Yes, it's one of the most important issues. Yes, it's one of several issues I follow. No, there are other more important issues. And no, the current state of healthcare is acceptable. Okay, and if we could just show that response. Okay, perfect. So clearly consistent with the last poll question, definitely something that we're all thinking about. So, and we also want to thank our team here for putting up the poll questions and displaying that as well. So thank you. So moving to next steps, what are examples of how we have effectively addressed these inequities? And where are some of the opportunities to improve the healthcare system in the future? Oh, we'll start with Dr. Lalani. Sorry. Oh, you're on mute.
Good. So I actually thank you for a very dynamic response to the last question, Henna. And I just want to remind, one thing I want to add to that is the fact that in 1986, President Reagan gave amnesty to all the immigrants. And that's why so much of our community are naturalized and have insurance, all of us, most of us included, right? And so exactly what you're saying is right now we should see our brothers, other minorities, and the Ismailis that still want to come, our family members that, this is the land of the free, and give us, you're tired, you're hungry. And that's feels like not only has to do with who the presidential candidates are, but it's really what this country is based on. This is a country, every single one of us on this panel is an immigrant. Every single person, white, black, brown in this country is an immigrant. And that's that policy of we should all become, have amnesty. So in that, and also, so what happened in Queens was that the Jamaat Khana was made in Rego Park. And so then the Jamaat, and this happens around the whole country, right? Is that the Jamaat then moves close to the Jamaat Khana. And so in Queens, there are very few hospitals. I've actually talked on a lot of panels for Queens about the fact that there are no hospitals in Queens because we have some of the best hospitals in the world in Manhattan. But people can't, when you're sick, you get an ambulance that takes you to the closest hospital. It doesn't say, let me take you to the fancy hospital in Manhattan. And so the Jamaat in Queens, there are no hospitals. That's what I was saying earlier. We had to transfer out 350 patients a week during COVID, stem all the way up to Albany, 4 hours away. And that also goes with the schools. On a side note, there are D-level schools in Queens. So it just kind of goes with what we're talking about, which is that where we live and what we choose and what our access to housing is all relates to our health and our care. On a more positive note, what your question was about was what are the improvements? And so I will say that since I finished med school 12 years ago, I've been definitely seeing an increase in the number of people that I can ask, do you have health insurance or not? Because that changes the name of the game for me on what I'm going to order, how far I can go in your testing, how far I can tell you how sick you are if you have health insurance or not, because I don't want to take your house. And so there's definitely an increase in the number of people that have health insurance. That being said, a lot of people, my friends included, don't necessarily prioritize health insurance. So we talked earlier about being able to afford it. But a lot of people can afford health insurance and aren't actually paying for it. They'd rather buy fancy clothes and fancy cars than, we're talking this whole call about health insurance, but I also implore everybody to buy it if you have access to it. But back to the fact that, yes, nationalized health insurance is the reason why more and more people are getting health insurance. There's Obamacare, there's Magellan, there's so many more health insurances that are available now, HMOs and PPOs. And so I can do my job better. And so I strongly believe, I'm partisan in this, that I really believe a nationalized health insurance is the most important thing. I felt that way since I was 17. I wrote my, high school thesis on it. And some people say, oh, that's socialism. But listen, we all have free education in America. And none of us say, oh, that's socialism. But it is, right? Your free access to health insurance anywhere in America is a government policy. It's taxpayers' money going to education. And I purport that health insurance is just as important as education. Because if you get education, but then you can only spend all the money you make on your health insurance bills, there's kind of, they understand each other out. Or actually you got sick when you're 16 and didn't get all your education, right? So I personally think, I'm biased, obviously, that health insurance is equally as important as education. And I don't believe it's socialistic. I think that in the new plan, in almost every plan in America, the plan is that there would be a nationalized health insurance option, and then you can get private insurance. Similar to, you can go to you can get public school, and then you can go to private school if you want. You can buy, I kind of liken it to, and then some people say that, oh, but the health system isn't as good in Canada or UK. But so I kind of say, like, in America, we almost have like a Louis Vuitton health insurance system, where some people have access to the best and the best and the best and get knee surgeries, plastic surgeries, eye surgeries, LASIK, all that stuff. And that's great. You can get that with your private insurance, but at what cost? It doesn't mean that the average people can't even get basics. I believe that we need to have, like, everybody gets Target clothes, instead of, like, right now it's kind of like a 99-cent store and Louis Vuitton, and there's no other choice. But there should be like a baseline. Everyone could shop in Target. Like, there should be a nationalized health insurance everyone could shop at. And then if you want more, if you want your nose job, hey, go for it. And it's available in America. Other benefits of improvements that I've seen in America in the 12 years that I've been since med school. One is what I mentioned earlier about language. So actually there was like no concept of interpreters when I was in college. And I did this small little project on how to be an interpreter when I was in med school. And now I wish I thought of it myself, but there's like video interpreters, phone interpreters. So in my hospital, in my emergency department, we have like 8 iPads on rollers, and you bring them into a patient room and you pick the language, Russian, Tibetan, whatever, and then they can interpret it for you. I wish I thought of it myself. I wouldn't have to practice medicine. I'm just kidding. Another thing that's improved is we have these things called patient navigators or complex care. So people that are constantly going to the emergency departments, there will be systems like administrators that can say, okay, you have a medical problem. Let us help you fix it before you keep coming to the emergency department. So there are ways to get better access to healthcare. Also, medicine and science is improving thanks to, educators like Henna, thank you. But like, so, right. And also, and also the insurance system. So right now we would admit you for like 4 days for chest pain. Now with the lab tests are so good that you can actually only be in the hospital for like 4 hours, get a good blood test. If it's normal, we can send you home. And even because of insurance companies, like we don't have to necessarily keep people for 5 days. We can figure out what the best care is to give you in 48 hours of staying in the hospital, and you can go home with oral antibiotics or whatnot. So medicine's improving, administration's improving, language options are improving, people are entrepreneurs, and hopefully at the end of the day, we'll get some nationalized health insurance. But at the end of the day, please at least buy what you can and don't prioritize your money on Louis Vuitton and fancy cars. Get health insurance.
It's great. I especially appreciate the Louis Vuitton and dollar store analogy. So we'll go to Alisha Lalani next.
Yeah, thanks. Fazila said a lot there, and I think that there has been over the last several years tremendous progress, and a lot of that comes from the Affordable Care Act, right? The uninsured rate has gone down to 8% in the U.S. It's unheard of. It's never happened. We've seen a lot of economic prosperity as a result of that, right? There's, like I said, all of these things are inextricably linked. So the economic boom that we've had, the uninsurance rate, those are related. And so much of the ACA that has come about beyond the uninsured, right? There's the other aspects of it was to improve quality of care, right? And to reduce cost of care, because all of those things were big items. So what the Affordable Care Act has done is said, let's shy away from fee for service. This is not an a la carte menu of here, the doctor prescribed this, this, and this, or we did this and this and this test. This is what it's going to cost. It's what were the outcomes of that test? How well did that patient recover? What were the patient's outcomes? And that's how you're going to get paid. Paying on the basis of quality was an Affordable Care Act provision. Same concept on reducing costs and improving member experience, right? So much of member experience and ensuring that a member has access to language navigators and peer navigators, again, all coming from provisions in healthcare, which really improved member access and their comfort with going to see a physician. So I think all of that has really improved as a result of the Affordable Care Act. I think the other thing that we've seen, and we've mentioned a couple times, is the social determinants of health. And insurers and providers and hospitals are really bringing this to the forefront of how they treat their patients, right? How are we thinking about their structural inequalities and their structural issues that they're facing, and how is that relating to their health outcomes, right? So now you can go to a physician and they can prescribe a healthy diet for you. If you're living in a food desert, if you can't get access to quality nutrition, I think we actually got a question from Ibrahim about this, right? If you can't afford the good produce and the fruits that make for a healthy diet, and then you have a healthy lifestyle, providers can now go in and prescribe you for a food pharmacy, a prescription for a healthy diet. And that makes a huge impact, right? All of that is new. Big insurers like United Health Group are putting $500 million into housing stability for members, and they're doing on-site care for those members. So you're seeing a lot of insurers, a lot of hospitals really thinking about the social determinants. And I think secondly, and it's a bit of an obvious one, is technology, right? Technology has enabled us to reduce gaps in care. And many of you on the phone may have had your first telehealth visit during quarantine. And this is a huge boon for the healthcare industry, right? To be able to even get primary physical care or behavioral health care and prescriptions from wherever you are, it is a big deal. And it didn't happen before. And, even overwhelmingly in lower income populations and Medicaid populations, over 80% of them have smartphones. So to be able to use mobile app technology to remind folks of medications, to remind them to see their doctors, or to check in on them, say, how are you doing? Or use any sort of remote patient monitoring so they're able to be compliant from their homes or from wherever they are is a huge boon to how we address healthcare and the healthcare outcomes that we have. And I think, in terms of further improvement, I think there's a lot of opportunity for growth, right? One is how do we continue to think of healthcare as an investment rather than a cost, right? How do we think of it as a growth lever? Focus on interventions that are preventative in nature, and how do we think about reducing barriers to care for, coverage to care for individuals, and what that means for, again, economic prosperity and what the return on is on that investment of healthcare. And I think being able to go through the provisions of the Affordable Care Act and do that at a local level, like I said, right, so many of the provisions sit at the state and local levels. So how do we ensure that those pieces and those components that are in the Affordable Care Act that really allow us to improve care continue to happen at the state and local levels is an important one. And I think that's why we're hearing about it, that's what we're talking about it. But I think that, thinking of it as more of an investment rather than a a burden and a cost that we have to face is a way that we can improve overall thinking about care.
Well, thank you. Thank you so much for that. It is reassuring to hear some of how the improvements that we've seen came to be, and also that's a helpful framing for future improvements in the space as well. So again, I know that there have been some hands raised. I just wanted to remind you all that I do want to make sure that we capture that interest. And if you could just please insert those questions into the Q&A section, we'll be heading there shortly. But before we get to that, we have our last panel question before we go to Q&A, and that is what to do. What advice would you give to those who want to get more involved? And we'll start with Dr. Budhwani.
Hi again, Yali. First, we all have different paths. I mean, years ago when I was in REC, we were taught this concept of the rainbow, where we all start different faiths, start at different points, but we all end up at the same place. Our path is different, okay? Now, as a sociologist, I believe that structure expresses greater influence on our behaviors as compared to agency. That means much of our behavior is conforming, right? We just do what we do without thinking about it. So behaviors are routine. We don't think about them. And because of that, we just vote the way we've always voted. We don't critically evaluate if our views have evolved or changed over time. So I think that's a starting point. And also, we vote on single issues because we understand those issues very closely. So as one key way to express our agency and our autonomy, which I mentioned we did when we migrated to this country years ago, is to vote, but to do so in an informed and thoughtful way. And that means we need to understand, in the context of this conversation, the healthcare-related policies of every candidate. Which candidate wants to ensure that your family has good quality healthcare? Which candidate supports body autonomy? Which candidate better represents the ethos of our tariqa, our philosophies of generosity, care for the poor, kindness, inclusivity of all diversity, and belief that the core of humanity is truly good? I would suggest you identify who that candidate is to you and vote for him, because that candidate will be a friend to your family, and I believe will also be a friend to the Jamaat.
Alisha?
Yeah, I think, Dr. Henna said a lot, but the ultimate piece here really is to vote in local elections, right? It's take this passion that we have for this election and take it to your midterm elections and your local elections, because so much of your provision and delivery of care and what gets regulated happens on the local levels and the state levels. And so this amount of interest and this amount of learning about and getting educated on the issues, do that on the local level. And I think that would make a huge difference here.
And Dr. Lalani?
Sure. First, before I say vote, I'm going to actually give a plug to what I think is the most important thing in the world, which is doing Seva. Getting involved, it just changed your whole energy, your whole vibe. The person you become is what makes you happy is, for me at least, what makes me happy is and gives me energy is serving others. And I believe that we're part of the privileged people, that are able to be on the Zoom, educate ourselves. And I believe the purpose of the world is to make the world a better place. It's so cliche, but I believe it's true. And so Hazar Mom has two quotes that I really resonate with. Is the question is not only what I have achieved, the question is, have I helped others achieve that? That's the notion of social consciousness in Islam. And so the number two thing is make sure you vote, right? And when you vote, who is the person that's actually caring about helping the whole of society? The other quote I love is, live your faith through acquiring knowledge with which to help others. So being on this call, educating yourself about inequities when you might already have good health insurance or access, and not be be getting equity, trying to educate yourself and figure out what the inequities are and making a decision based on that. 52% of you said you're going to make your decision based on that. That shows that you're already part of social consciousness, and make sure that you give that back to the community. My sister started volunteering in her late 30s, and now she kept getting pushed up, and she's the chair of ECDC as a doctor, right? So it doesn't also have to be in your area, but just make sure that you're giving back to, if not Jamaskana, but that society at large. And then exactly, I agree with what everyone's saying, is when you choose to vote, first of all, take the time. This is the 100th anniversary of women's right to vote. So every single woman should really be enjoying that, appreciating that, and what all the women ahead of us fought for. And just think about, if you benefited from free education, and you should benefit from free healthcare, in my opinion, and vote for the person who's going to provide that, and be socially conscious.
So I'm definitely fired up, and I hope a lot of people in the audience are as well. So we will be moving shortly to the audience Q&A. So we encourage you to put in those questions that may be marinating that you haven't put into the chat box yet. But before we go on to that, the last piece that we'll do is a final poll question. So if we can have that put up. And it is, I know of at least one way that I can become more involved, and we gave you a little hint. Okay, great. So absolutely, voting is something that, and we'll go ahead and share those results. Voting is something that everyone has mentioned, both in, we've mentioned the presidential race, but in addition to down ballot local races. And of course, we've also noted that the work definitely continues beyond that as well, in many, many ways. So we will go now to question and answer from the audience. We also wanted to note, just as we conclude the prepared questions, that there are many groups with comparatively higher rates of illness, misdiagnosis, suffering, and death in the healthcare system that we haven't mentioned today, but who are no less deserving of our attention. And that includes the LGBTQ population. It includes the Black and Brown community, as well as those who are undocumented immigrants, and we touched some on those who have poor English literacy. So these are but a few of the groups that we should also keep in mind as we endeavor to improve the inequities in our healthcare system. So with that, let us move to our first Q&A from the audience. As we talk about reducing healthcare inequities, one solution would be single-payer universal healthcare. Yet as a nation, we shied away from supporting universal healthcare. Why is this, and how can we go forward? And anyone can respond.
I can start, and I think I can build on it. I think currently in the US, and I think I mentioned this, right, we have multiple parties that pay for healthcare. We have private insurance companies, we have employers, we have the government, and then we have individuals. And universal healthcare would make it so that one party, in this case the US government, would pay for healthcare. And so and the different proposals that we saw, throughout the presidential race, we've seen, different versions of what this would look like, what Medicare for all would look like, what other pieces would look like. And in these situations, private health insurance would look really different. And so how do you, one, think about dismantling a system that exists and is so embedded across everything, right? How do you think about the lobbying dollars that pharmaceuticals and private insurers give and pieces like that, but also to the point that Fazila made around different countries and what they have, and having a hybrid system that would also require government and the American system to think about a requirement to have insurance, right? A universal healthcare system would only work if we allow or require healthcare to be a part of it, be a requirement. So the individual mandate, which was part of the Affordable Care Act, was shot down by the Supreme Court last year, right? Because that required every single person in the United States to have insurance. And if they didn't, they would have a tax penalty levied on them. So, and that was removed. So if we were going to have a universal insurance system, that would need to be reversed. We would need to require people to have insurance. And how do we make sure that happens? And how do we make sure that that stays American and against our Constitution? So I think that's some of the issues that we're facing, but also in terms of taxes. And I think there was questions on taxes, right? It's people don't want to see an increase in taxes, but if those taxes came from the premiums that you're paying and the high medical bills that you're paying, how do we sort of balance what that would look like, and what would those dollars look like in a universal healthcare system? And so I think finding a way to have a hybrid approach is probably something that makes sense for this country, given where we are and how we're embedded. And so thinking about really expanding that ability to have public insurance, which again, I think the ACA has done, and I think that there's opportunity for that to grow, but also regulating more the private insurers and making sure that there's some equitable benefits and also equitable costs, right? As Fazila mentioned, so that people are not, the public insurance is not just dollar store insurance, and the really higher income, the haves will have the Louis Vuitton, and then there's a big disparity, because that really increases and exacerbates the social inequalities that exist. So how do we ensure that there's some equitable nature within both the public option and a private option? I think that those are some of the issues.
May I chime in?
Please.
Awesome. Okay, so boiling it down to stuff that's very simple. I think number one, people are scared of what they don't know. In the United States, we don't have universal health care. We don't know what that looks like. And the Jamaat talking about like Barkat uncle and Shabana auntie, they don't know what that means. I don't know what that means. I don't know what universal health care when implemented in the United States would look like. And I think there's a huge amount of fear around that. I also, to Alisha's points, years ago, before I joined the university, I worked at Blue Cross and Blue Shield and had a great experience there. But the thought that we would have to completely get rid of private insurance to go to universal single payer, that's daunting and scary and unnerving. And while there's diversity of opinion on this panel, I don't know what a reasonable and viable path looks like to have national health insurance. I'm supportive of it, but I think the Jamaat, especially more thoughtful members of the Jamaat, want to know how we're going to get there. And I feel like if we can clarify that a bit more, we can get much more.
Sure, but I think you're against it. Okay.
While you guys were talking, I was trying to Google, like, when did education become free? I'm saying the same thing along the same lines. Education only became free in 1910. That's what I found out. Right? So same. At that time, everyone was against it as well. But I guess I'm echoing exactly what Henna said, is that people don't know what it's going to look like. They don't want to lose what they already have. But and then people that don't want to pay more taxes are saying it's going to be, oh, that's socialist, and so it's becoming, instead of equalizing with other things that we have that are socialist, which is streets, traffic lights, things like that. It's like, these are basic things that we need. I think that's why people don't want to pay more taxes.
I agree. I also want to say this, and I think this is important. And I think the panelists, we all had this discussion. So when I teach graduate students and undergraduate students and even medical students, I really push hard that we need to call things what they're called. So it's the Affordable Care Act, right? Because when we call it Obamacare, if you've got people who, for whatever reason, don't like President Barack Obama, they instantly flinch. And so I'm in the midst of the deep, deep, deep conservative South. And if I talk to folks about provisions within the Affordable Care Act, regardless of political affiliation, they're like, oh yeah, that's good. We want people to get the medications they want, and this is great. But if I call it Obamacare, everything falls apart. And so I think we also need to be, there's some questions that have been coming in about how we have these discussions. I think it's important that we acknowledge the language matters, even within something as so innocuous and seemingly non-political as healthcare. So that's just my personal opinion, is I prefer to call it Affordable Care Act.
Yeah.
So oh, good.
Sorry. But just as also, I just Googled like maternal death in America, right? So if we consider this health insurance so great that we have, but it's really not. So this says the US is the only industrialized nation with a consistently rising maternal mortality rate, despite spending more per capita on healthcare than any other country in the world. So even though we have Louis Vuitton, if you guys have Louis Vuitton, sometimes they break down. Like, we don't necessarily have the best healthcare system just because it's not socialist and it's capitalist. It doesn't mean.
I like the dollar store. I like Target. Yeah, we're the poor community that's, yes. So I'm right there with you.
Great, no, thanks. Okay. Sorry, did you want to add something else? Okay, great. Well, I'm glad, Dr. Budhwani, you also segued us nicely into the language that we use when talking to others about it. Our next question is as follows. Our vote matters and our Jamaat should be well aware of it. My observation is that many of our Jamaat do not know its importance. How can we better talk about things like democracy with our kids and family?
What was the question again? I'm sorry. I was looking at a text from an amazing panel attendee who was asking me how my family was doing, which is really sweet. But what was the question? I'm so sorry.
No problem. My observation is that many of our Jamaat do not know the importance of voting and how our vote matters. How can we better talk about things like democracy and with our kids and family?
So you know what I think about? This is really off the cuff. I haven't seen this question before. You know, if any of you have been a uniform volunteer, like my 9-year-old twins, the badge they have, it says work, no words. And the undercurrent to that is we need to emulate the behaviors that we want the Jamaat to replicate, right? So when I do behavioral change interventions with adolescents, the quickest way for an adolescent to completely go against what I want them to do is to tell them what to do. And I think humanity just doesn't like to be told what to do. But what we can do as people who are on this session is we can vote and we can broach these conversations gently, and we can choose not to shy away from topics that are a little bit tough. And we can go out there and do this. So a resource I shared with Faiz and the team was a program through the Robert Wood Johnson Foundation called Leaders in Terms of Cultural Health, or I don't remember the actual term. Most Jamaati members that I've met are involved in Seva, and they're committed to making a difference. So apply to these programs and become leaders in the community. That doesn't mean political activism all the time, every time. If you can, and that's who you are, great. But it's just be a part of the community in the Jamaat and beyond the Jamaat, and then be open to answering really hard questions, because younger members of the Jamaat will send me a text, they will send me an email, and be comfortable to have those conversations. So work, that the badge says work, no words. I would say work and words in this context.
I think the other thing in talking and teaching about democracy is how do you get out of your bubble? And so many of us now, especially given the current circumstances, are in a bubble or live with or hang out with, interact with people who are very similar to us in socioeconomic status, educational background, and the way we live. So seeing the inequities, seeing how our democracy works for different subsects of the population is really important. And so how do we ensure that in some ways, whether it's the way we volunteer or the way we interact or who we interact with, and how do we work across these social divides that we sort of create for ourselves, right? I live in Washington, D.C., and 2 miles down the road is a very different city than where I am right now. So how do we make sure that we're spending time there, that we're patronizing those stores and those restaurants and even those smallest things? But how do you do more beyond that to make sure you're understanding what the world looks like beyond your bubble? And I think that that's really important, how you teach democracy and what democracy's impact is on your community, even just a few miles down the road.
Yeah, and just to add similarly, but one of the drawbacks right now of the fact that we have to be social distancing is that we're not out there having the family conversations, the friends conversations, trying to engage and have, discuss what's going on the ticket. And so I was at a family dinner recently, like a mixed group, and we talked about health and about the election. And in retrospect, I realized that it became so one-sided. There were like 5 of us who were on one party and one person that supported the other party. And we really kind of just talked at that person as opposed to just asking them to they gave a response about why they wanted one candidate. And we all ate her up, as opposed to saying, okay, speak up to that, speak to that, speak to that. Let her let that person get to the end result. Keep asking, okay, and why, and why, and why, to get to that person's, what's the core behind that person? Why did you say back, oh, healthcare socialist? I went back and talked about the same topic. The person said, oh, nationalized healthcare socialist. And I talked about all these examples I've talked about today. But instead of asking, what are you afraid of with healthcare socialist? What's going to happen? Instead of attacking her, letting her talk and get to her fears at the bottom and addressing that. That's what we do as humans when we're caring for each other. And so this is a time where we really need to care for each other. And I see Oprah is making phone calls and this person's making phone calls, and I haven't done, but it's something that we should be doing ourselves, calling the people and having these conversations because we're not meeting up with them for dinner otherwise.
Great. So we have a few more questions. So I don't know, maybe for the sake of time, if we could have like maybe 1 or 2 panelists respond. Of course, we won't enforce the rule, but as we go through the final few questions. So our Jamaat is reflective of broader society in many respects, including wealth inequities and inequalities, which has been covered as a contributing factor in how we consider approaches to healthcare. What suggestions do the panelists have for not voting against our collective interests, and how do we take that leap of faith?
Can you repeat the question?
Sure. So we have, our Jamaat is reflective of broader society in many respects, including wealth inequities and inequalities, and these contribute to how we approach healthcare. What suggestions do you all have for not voting against our collective interests, and how do we take that leap of faith?
No one wants to take this? Fazila, you look like you want to talk. I'll let you go.
No, go ahead. I'm thinking.
Yeah, so am I. I think there are a couple things in this question. And the first that pops to mind is this is something that Chairman Zoré, and before her Chairman Shamsha, and before her Chairman Mahbub and Chairman Fatima Mauji, all chairs of the National Social Welfare Board, have struggled with, right? In terms of the most disadvantaged, poorest, most in jeopardy members of the Jamaat. This is the institution that represents their well-being. I think going back to my comments on agency and autonomy, we have to respect people's individual views, right? So I can say, I believe voting for this person is going to hurt the Jamaat, and I sincerely believe it, right? But my fellow Jamaati member in Birmingham may feel very differently, right? And may see the world very differently. And he or she is entitled to their beliefs, he, she, or they, right? I also think that, and I mentioned this earlier when I was talking, the Jamaat tends to focus, in my limited experience, on single issues that are really important to them. And that's not just something that affects the Jamaat, it also affects the broader community because they understand the issue and they understand the implications of the issue. So if you raise the minimum wage, what does that do for the gas station owners and the C-store owners in our community? It directly affects their bottom line because if they're paying current minimum wage, they're effectively having to double what they pay. And so I think that we need to reach beyond the people we normally talk to. So I think Alisha talked about getting outside of our bubble. I'd be considered a professional, but, a lot of my friends and family aren't. And so we can have really thoughtful, informative conversations about what's important to them and how these issues that are important to me, maybe they haven't given a lot of thought to. So I think I don't want to say it's education because that sounds very dictatorial. I think it's just about engaging in open dialogue, and truthfully, sessions like critical conversations are a pathway. This is a mechanism for people to have conversations on difficult topics that may, move folks one way or another. So.
I also think thinking about how we take the way we act and our ethos inside the Jamaat kind of walls or within our Ismaili community and think about that broadly, right? Within Jamaat kind of with our Ismaili brothers and sisters, for those who are in need, we have so many resources, we have access, we have all these things, and people who are so willing to give of their time, of their resources, of monetary funds, all of those things for people in need. But thinking about how our Ismaili brothers and sisters in need, what they're outside of the Jamaat kind of walls, what are the structural issues that they're facing? And how can we support them broadly beyond that? And who are the other people that are suffering from similar plights, right? So how do we think about the magnanimity and the generosity that we have within our Jamaat and for our Ismaili brothers and sisters, and think about that as with our community at large? And I think that's a really that's something that I often see discrepancy in, but is an important thing to think about.
Dr. Lalani, I knew you. Okay, all right. So we'll go to our last Q&A question. As has been discussed, it is distressing for us when we meet Jamaati members who cannot seek care because they lack health insurance. While we hope that universal health care becomes a reality, that goal is still likely to take a while to be achieved. In the meantime, what resources do we have that we can direct these Jamaati members to help decrease those inequities?
I'm going to jump in because I'm social welfare. I'm so sorry. By the way, Alisha, your father-in-law texted me. He's super proud of you. Okay, so my roots are in social welfare. Let me tell you the best thing we have that other communities lack, and this is from my heart, is the Jamaat. So I remember years ago sitting at a table in Houston with the leadership of the Golden Club. And I was like 30-something years old, and I'm like, how am I going to command any respect by these elder leaders of the Jamaat? And they would tell me stories where one Jamaati member had lost his job. He was 60-something years old. So another senior member of the Jamaat, his son owned a Subway, so they would cook over there, but he couldn't drive. And so then another member of the Jamaat who could drive, who was, doing finances for his kids' businesses, would drive to that Subway, pick up the food, and deliver it to the person who was unemployed. So there are local resources. And I think the typical answer is, look at and this is true, look at what your county is offering, look at what's available in terms of charity care, look at indigent care that can be provided through different systems, Cook County Hospital being one of them. I would also say, don't underestimate the heart and the love of the Jamaat, because I will tell you, regardless of my relationship with anyone in Birmingham, if something bad happened to me, if I needed something, the Jamaat would corral and make sure I was okay and make sure that I would get health insurance, or not health insurance, but healthcare to the best that could be afforded. So we are very, very lucky to have the Jamaat that we have.
Yeah, and I think that's the theme of this, is that if we could, what Alisha just said, is that if we could see the whole country and the whole world as we see our Jamaat, everyone as our brothers and sisters, we would always be working to help other people, always be considerate of everybody around us on our street, in our hospital, and the world would just become a better place. I mean, that's so simple. I mean, just all of our mindset, how we are growing up as Ismailis, if we could be that way to everybody. And the other thing I was going to say is that every city, every state does have your nationalized health insurance, like city hospitals. So you can find where those are. Also, what a lot of people don't know about is that most teaching hospitals have clinics for their residencies. So even like an ear, nose, and throat resident will have a clinic so that where they'll see patients without insurance. So that's something you could do. People can do is call the teaching hospitals and find out where they are. And also get an annual visit. Go get your mammogram at 40. Go get your colonoscopy. Get your annual visits. Get your screening tests at the free places, so that you're less likely when time comes to need to have the big heart attack, because you were on the medications all along. So if you pay, paying for the medications for 10 years is going to cost much less than never being on medications because you didn't want to go to the city hospital and then winding up having a heart attack. That's what happened to me yesterday. I had a patient who came from Ecuador 2 years ago, never went to see a hospital doctor when he was in America for 2 years. His blood pressure was really high. So I do the basic blood test, and his kidney function is unfortunately very high. And so I have to hospitalize him. He's going to get dialysis. That's what we're talking about is going to happen to him. And if he probably just went to see the city hospital on the way, he wouldn't be having this catastrophic results at the end. So it's very real.
I had my mammogram last week. I'm good.
One more plug, and I'll stop talking. It's election season, but it's also open enrollment season, right? So all of the pieces that are available, any healthcare navigators that you need to help you understand what are the options that you have. States are providing it, private insurers are providing it, because everyone wants your business, even government, even private insurers. So take advantage of that. It's open enrollment season for the next few weeks. And so now is the time to ask all of the questions to all of the resources available to you.
So perfect. Thank you so much to all of the speakers for contributing to this discussion and providing your insight and your motivation. Thank you for the audience, members of the audience who chose to join us on Zoom on a Sunday, as was mentioned, and to those who submitted questions to us as well, and for the team that helped us put this together. Hopefully, this is just the start of the critical conversation, and I hope we'll continue to be motivated to participate in the political process and also continue to push for progress in these issues even beyond November 3rd. So a couple of announcements before we go. You can get registered to vote, check your registration status and more at b.ismaili/USA/vote. We'll put that in the sidebar. You can also call our hotline for support at 202-854-VOTE, 202-854-VOTE. Election day is Tuesday, November 3rd, and do note that early voting has already started in many states. Please look out for more info on the .ismaili/USA webpage and social media pages for young adult conversations this week and for our next critical conversation. And please take the survey at the end of the session that will pop out on your screen as you leave, as this will help guide us in the future. We'll also be sharing a few resources by the panelists. We'll also have that be placed into the chat box as well. So thank you, everyone. Thank you so much, and